Mark Feely and members of the audience, with your indulgence, we're going to extend this session for 15 minutes to allow some time for discussion, and that will cut 15 minutes out of the lunch. We'll have a 45-minute lunch, and if those of you who need to leave, please feel free to do so. But I think it's important that we have some time for some questions and discussion.
Thank you, Dr. Goldman. So we'll now open this up for questions for Dr. Chambers and Dr. Lipschitz. Yes?
Thank you, Dr. Feely. Dr. John Higgins from the University of Texas. My question is to Dr. Lipschitz. Do we think that the vulnerability in these children is related to the higher doses of the caffeine per body weight, to other factors, and or to an underlying cardiac defect, and particularly in the cases where there were sudden cardiac death and actually they either were brought back or survived or did not make it? Were those individuals? Do we have any data on what percentage of them had underlying cardiac abnormalities?
Well, I mean, I don't really. I like to let data drive policy and thoughts. That's why you didn't see any of the speculation really in here. But what I would say is when we have agents that we treat children with that have biologically active properties, as pediatricians, we usually dose by weight, by body surface area, by lean body mass, as we mentioned yesterday. We use a variety of different ways. If I have a 70-pound cheerleader, a 250-pound football player, they're both in the same situation, consuming the same amount, it's not how we would dose a medication that's biologically active. What that means in terms of endpoints, I don't really want to get into. What it means for a general population versus some of the specific higher risk groups. You know, as a cardiomyopathy, heart failure cardiologist for children, I have spent 30 plus years counseling them to avoid certain things that may trigger hemodynamic events or arrhythmic events. And what's the basis? It's really, it's mostly anecdotal. And in terms of, are they at increased risk? Yes, we've published that data for all of North America. They're higher risk for these. But is there the data right now to say, in a highly vulnerable, suspected population, what is the threshold for safety? What is the threshold for events? Data is not available. So in the absence of that data, when you see a safety signal, that's where what I said, what we usually do, unless there's a significant therapeutic advantage, we try to avoid. And that's where, again, the national organizations, totally independent of I had nothing to do with it, have come to a similar conclusion.
Sure. And would you support a national registry for tracking these events in children and having mandated reporting of those events associated with energy beverage consumption?
I think, you know, if we really want data to drive decisions in a situation where it really has, you know, can you criticize the NPDES? Totally. I heard that yesterday. I could tell you all the reasons why it's less than perfect. Are there biases? Absolutely. But in the absence of having any other way to really track in a semi-systematic way, it's about the best that I know that we have in this country for these type of products. This is not an area where FDA, I mean, as a provider, yeah, I could write a report, I could send it in, whether that's actually reviewed or not, or it really varies. So do I think that if others feel as I do that this is an area where there's enough safety concerns that there really should be the ability to look at this more carefully and let data drive decisions? Of course I support that, yeah.
Great. Thank you.
Hi, my name is Rick Kingston. I'm with the Safety Call International Poison Center at the University of Minnesota, and these comments are for our question, actually, for Dr. Lipschultz. Maybe in preference to my comments, I was previously the director of one of the largest regional poison centers in the country, the Minnesota Regional Poison Center. So in my 35 years of poison control experience, I probably contributed about 50,000 poison control calls to the database myself personally, not counting the ones that I've supervised. And I was struck by, when you were discussing the analysis of the energy drink toxicity in the National Poison Database, which is the topic in the publication that you were referring to. And when you were describing some of the data, as I mentioned yesterday, when you looked at the cases, you specifically said this morning, half of the poisonings, about 51%, involve children less than 6 years of age. And I was struck by that term because when you look at the 717 cases of the 1480 that you had in there, and you break out the outcomes, of that 717 cases, we have countless cases in there where a parent calls into a poison center specialist gets the call and finds out that the child came in contact with residue from a 5-hour energy drink or a Monster drink, touched it to their mouth. Poison center specialist says, that's no problem. No toxicity is expected. It's so trivial, we're not going to call you back, so it doesn't go into your no effect category because we don't follow it. And the vast majority of the events that are in that 717 actually fall into those categories. So when you look at the actual reports of adverse effects in that 717 pediatric patient population, it's 82%, as I could calculate because you didn't list those in the report. About 82% were no effect reported whatsoever. So my question to you is that, do you understand the difference between poisoning and exposure as they're reported in this database? Because it didn't appear that that was the case when you made your comments this morning.
Again, I appreciate your comments yesterday and your comments today, and I think this is part of the type of discussion that really needs to happen when we find safety signals and we want to go beyond that in terms of saying, really, are they accurate? Are they not? Are they acutely severe? Are they less severe? Are they more generalized? Are they specific to subpopulations? Again, your points are well taken. The fact that you could calculate how many were at different intensities speaks to the fact that to the extent that we had available data that was in a full disclosure mode. The interesting and frustrating thing for me as a clinician is that, you're torn. We wanted to get out the initial first year data. We're working now on the first 3 years of data because you can overinterpret really limited data with limited number of patients. And I think that this type of dialogue is really helpful as we look at how do we interrogate what we have. One of the things that was frustrating to me as a clinician, it touches a little bit on what you're saying, is the level of follow-up in the NPDS to verify facts, to really ascertain outcomes and the like. It's a very imperfect system. And I applaud you for bringing up some of the limitations. And when I use the term poisonings, it's because it's a definitional term. I just chose to use it because these are calls to regional poison control centers where they were logged in. So as a clinician, I very well appreciate the difference in somebody that winds up in an intensive care unit versus somebody that gets advice without recommendation for further medical follow-up. That's where, for example, in the data that I presented and we published on caffeine, I broke out those categories in terms of just what you're saying. It's critically important to do that. I think that with that data, it was more mature. And again, I think that the question here is, whether you look in Germany, Australia, New Zealand, Ireland, half a dozen other countries, the United States, it's not that we're seeing, here's an anomaly. We're seeing very similar findings to what other countries and other years have as well. So I thank you.
Just in follow-up comment to that, I'm completely with you on the post-market surveillance side. But I think that what we have to do is step back and realize that when we make these categorical statements like this, it really doesn't inform the discussion. It really exaggerates and sensationalizes the numbers where it's unnecessary.
Well, you see, this is, it's okay for reasonable people to disagree, because one of my concerns is part of what we heard yesterday was, again, there's an unknown degree of underreporting, misclassification, and things that really can't be quantitated in terms of consumption data, as we heard from 2 different databases yesterday that were very carefully looked at by excellent scientific groups, the ILC group and the CDC, continuing study. And I think that if one were to rely on consumption data alone, where again we don't really know what the impact, without looking at health consequence data, it would be misleading. So this is where, however we can get safety signals, that's where the Dawn data. Yes, people commented yesterday on, yes, there was a consultant report saying there's all this list of problems. There's not one perfect way to ascertain this when it's not being tracked in a systematic way. So the question is if you say, gee, there's essentially no consumption in young kids, and then you're seeing all around the world that, gee, we're seeing really toxicities, then you say, I might be wrong, but that might suggest it's even more of a vulnerable population, that is children. And the point is you could jump to almost any conclusion you want. The only thing we have that's true is that we are getting calls by a variety of different people that relate to temporal associations with these products that are largely unverified, but are being found as at least safety signals that go along with what we started seeing at the bedside and in the clinic. And again, that's where a forum like this is so valuable, because it promotes dialogue and it hopefully leads to the next level of higher quality science.
Okay.
I agree with you 100%. All I want to say is I just think we need more transparency in the way that you present the data. I could figure that out because I've been doing this for 35 years and I contribute those cases, but I think the average people that are looking at this report don't have that same benefit.
Yeah, these are all good comments. I think we can carry this on into the after lunch session on data gaps, so we can complete it by 11:45. Next, thank you.
Jeff Goldberger, Northwestern University. Dr. Lipschutz, that's a great presentation. I just have one question. In the poison control data that you looked at, once the energy drinks were classified separately from other caffeine exposures, were you able to compare the characteristics of those 2 kinds of exposures?
Thanks, Jeff. And again, I didn't want to do that specifically with 1-year data. That's part of what we're doing with the 3-year data, where we have greater ends, the same way we presented 3 years of data there. Because I think that's a really important question. As the last session, is there a different toxicity or therapeutic profile between caffeine alone versus combination products as found in energy drinks? Great question. Thank you.
Hi, Lynn Goldman, George Washington University. I have a question for Christina Chambers, just to switch the focus a little bit. I was very happy to see your presentation about the epidemiology of reproductive effects. And one point I wanted to make is that you made a statement that seemed to say that if early spontaneous abortions had genetic abnormalities, that would be a non-environmental cause. But of course, there are environmental mutagens, and so that those could be environmental. But I would like you to comment on the evidence in terms of mutagenicity of caffeine. As far as I know, there is none for it. The other comment I wanted to make was on your interpretation of I think the Kaiser study. You inferred, because there was not a monotonic linear dose response within the range that they were studied, that therefore that would be evidence that there's not an effect on spontaneous abortion from caffeine. But that's an assumption that the mechanism would involve a monotonically linear dose response. which it may not. I mean, oftentimes for exposures environmentally, these are log linear responses, other kinds of responses. It could be that the response is at a lower level even than the lowest level that you were looking at. So I would just be cautious about that. Of course, it's also possible that people who drink coffee are simply involved with other lifestyle factors that are involved with spontaneous abortion. That is also a possible interpretation. But I just wanted to be careful about that.
Those are great comments, and I think you're correct in terms of the lack of data supporting a mutagenic effect of caffeine that might in turn lead to genetic causes of spontaneous abortion. And I think the point that you make about the dose response thing was really not in relation to spontaneous abortion, but the data in relation to small for gestational age. And you're absolutely right, and certainly we've seen things like that with smoking, where you look at risk for craniosynostosis, for example, where you see an effect at low and moderate ranges, and then you see no effect or a reduced effect at the highest dose. So it could be that it's a nonlinear relationship. It could be that that at higher doses other things are going on, or it could be that people who make it to live birth are more likely to make it to live birth in the small, low and moderate dose range, and not in the high dose range. So definitely not totally ruling out that there is an effect.
So I think we have time for just, unfortunately, one more question, and we also have a web question that comes in that I think will be very quick to clarify, and then any additional questions we can save until the afternoon. So.
Roland Griffiths, Johns Hopkins. This is for Christina Chambers. Just a comment and a question. So I'm very interested in relating back to our discussion of yesterday to compliance with instructions from physicians to give up caffeine. And I think it's particularly interesting for women because they're coming into a situation where they've perhaps developed normative lifestyle, and then all of a sudden they may get this quit instruction. We did a study with Dasi Savickas about 5 years ago where we gave a strong instruction to women who were newly pregnant and found that some, and the instruction was to quit. We found some did, some didn't. But the interesting thing, and perhaps predictable, were those with that met diagnostic criteria for caffeine dependence were those that tended not to. But there was a subgroup, and this is a vulnerable subgroup of those. If they had a family history of alcoholism and caffeine dependence, 50% of them continued to use caffeine at levels in excess of 300 milligrams, which is the Health Canada cutoff, and about 43% continued to use in excess of 400 milligrams. So they were totally non-compliant. So my question is, what do you know about compliance with this instruction in this population?
I could say I know nothing, but I suspect compliance is not good with anything where you tell a woman to stop doing something in pregnancy. She'll tell you she's compliant and then not be compliant. But I think that you're absolutely right, and I think that was the point I was making about the co-behaviors that go along with particularly high consumption, and then the subset of women who really might be have an addiction to caffeine along with other substances, being particularly recalcitrant to reducing consumption levels. And I think that's an important question. The other thing you raised, which was an interesting point brought up in the earlier talk, was the concept of withdrawal. And I don't think anybody's ever looked at that in pregnancy, and the symptoms of withdrawal are quite similar to some of the symptoms of pregnancy as well. So it'd be an interesting question.
So before we end the session, we have actually one question from a web attendee. I believe it's directed towards Dr. Lipschultz. And the question is it accurate to characterize all reports to the poison control centers as poisonings? Do those discussing poison control center reports separate actual poisonings with adverse effects from other self-reported exposures of concern?
I think that's something that I just tried to address. It's a semantic issue where we're using, if somebody makes a call to a poison control center, Their concern is there a poisoning? If the Poison Control Center says there's merit in noting and tracking this, that definitionally was what we used.
Okay, no, I think that's clear. I wanted to thank the panel members, Dr. Chambers and Dr. Lipschultz, for a very interesting discussion, and now we're adjourned for lunch.